Welcome to Ortho Reports podcast. Today we're doing a deep dive into a really fascinating and pretty rare case.
Yeah, we're talking about inferior hip dislocation. You might also hear it called Luxatio Erecta Femoris.
Quite a name. And it's significant because it's not your everyday hip dislocation, right? It's quite distinct.
Exactly. It accounts for maybe only about 5% of all traumatic hip dislocations. So uncommon, definitely an orthopedic emergency when it happens.
Okay, so rare but serious. We're going to unpack a specific case report from the Journal of Orthopedic Case Reports today.
It really highlights the injury, how it was managed, and some key learning points.
Great. Okay, let's unpack this.
What's fascinating here, I think, is just how understanding these rare cases is vital, not just for orthopods, but, for anyone interested in how the body works and sometimes breaks.
Right, so this inferior hip dislocation, Luxatio Erecta Femoris, what's actually happening there, mechanically speaking?
Well, it's almost always linked to high-energy trauma. Think motor vehicle accidents, falls from a decent height.
Yeah.
The specific mechanism involves a pretty significant force hitting the hip while it's flexed and abducted, so bent and out to the side with axial loading. Pushes the femoral head right down inferiorly out of the socket.
And that's what gives it that Luxatio Erecta name, the erected dislocation.
Precisely. On an X-ray, the femur often looks almost perpendicular to the spine. It's a very striking image. The leg is essentially forced upwards because the hip joint is dislocated downwards.
Wow. And I guess with that kind of force, there's often other damage, like fractures.
Very often, yes. Associated fractures of the femoral head or neck are common, which just underlines the severity. People like Mock and Anderson back in 35 and later Rico and Barquet in 82 really pointed out how unique this presentation is.
Okay, so let's dive into the case report itself. It involves a 60-year-old male patient.
That's right. He experienced a fall from about 10 feet.
And his presentation in the emergency room, this is where it gets really interesting, paints that picture you described.
So he comes in, he's conscious, oriented, vitals are stable, GCS 15, BP 130/90, pulse 88. Pretty stable considering the trauma.
But his leg?
Yeah, his left leg told the story. He's lying supine, left hip flexed at 70 degrees, left knee bent to 90 degrees, and the whole limb is externally rotated. That classic, almost frozen posture.
That's the visual cue then. So what's the immediate diagnostic process?
First things first, a thorough systemic exam. With high-energy trauma, you have to check for other injuries.
Yeah.
Head-to-toe assessment.
Absolutely.
Then confirmation with an X-ray. Pelvis, both hips included for comparison. And there was clear inferior dislocation of the left hip.
And at that point, it's all about speed, right? Emergency situation.
Absolutely critical. Swift action is paramount.
So treatment, what did they do for this patient?
They performed a closed reduction under short-duration general anesthesia.
Meaning no surgery, just manipulating it back into place.
Correct. Which is preferred if you can do it safely and quickly. The technique involves sustained traction, pulling towards the patient's head to overcome muscle spasms and the dislocation itself.
Okay.
Followed by gradually extending the thigh while internally rotating the hip. Needs a careful touch.
I imagine the anesthesia helps a lot with muscle relaxation for that.
Oh, definitely. Makes the whole maneuver much easier and safer.
Yep.
It's considered a very effective method when done promptly.
And then you check your work, I assume.
Always. Post-reduction X-rays immediately to confirm a good concentric reduction, the ball perfectly centered in the socket.
Right.
After that, immobilization, in this case a long knee brace.
Right.
And crucially, they also did an ultrasound of the abdomen and pelvis to rule out internal injuries.
Which thankfully were normal for him.
Yes, normal findings, which is always a relief after that kind of fall mechanism.
Okay, so here's the part that seems quite remarkable. The recovery.
It really is.
Full weight bearing the next morning after that kind of dislocation.
Yep. Allowed full weight bearing, ambulating independently the next morning, and then discharged. Wow. It sounds amazing, and it is, but if we connect this to the bigger picture, it really highlights how effective, timely, and correct intervention can be. It's a best-case scenario, for sure.
And the follow-up supported this great outcome.
It did. Followed up at 2 weeks, 1 month, 3 months, 6 months. Continued walking without assistance, no pain, no limp. X-rays stayed normal. Fantastic result.
That's genuinely impressive. So stepping back from this specific case, what are the big takeaways, the key learning points from this report and others like it?
Well, first, it reinforces the rarity less than 10% of all hip dislocations. But because it's rare, early recognition is absolutely crucial. That atypical limb position is key, but you need to be thinking about it.
Right. It could be missed if you're not looking for it specifically.
Exactly. And the second major point is timely reduction. Getting that hip back in place, ideally within 6 hours, is essential.
6 hours. Why is that window so critical?
The big risk is a vascular necrosis, AVN, of the femoral head. Basically, the blood supply gets cut off and the bone tissue can die.
Oh, wow.
Yeah, it's a devastating complication. Can happen in maybe 10% of cases, but that risk shoots up dramatically if reduction is delayed beyond 6 hours. It really underscores the emergency.
That 6-hour clock is ticking fast in a trauma situation.
It really is. It means this injury needs high priority, even if other things seem more immediately life-threatening initially.
Makes sense. What else?
Third, remember the high-energy mechanism. Always do a thorough systemic check for associated injuries, especially pelvic organ damage. Don't get tunnel vision on the hip.
Good point.
Fourth, post-reduction imaging is non-negotiable. Confirm the reduction is concentric, check for any loose fragments in the joint, double-check for those internal injuries with ultrasound if needed. And finally, remember it's not just adults. Pediatric cases happen too, so awareness across all ages is important.
So this really raises an important question then, doesn't it? How do we ensure these rare, time-sensitive injuries are always caught and managed effectively?
That's the challenge. It comes down to continuous education, solid trauma protocols, and honestly learning from every single case, like this one.
Yeah, this case report really drives home the value of quick diagnosis, precise action, and just how good the outcomes can be with vigilance, a testament to careful work.
Absolutely. And it makes you think, doesn't it? What are the remaining challenges in trauma care for these rare but critical injuries? How is sharing this knowledge, case by case, actually push medicine forward and improve safety for everyone?
Definitely food for thought. Every case teaches us something.
Yeah.
Well, thank you for joining us on this deep dive. It was truly a fascinating look at a rare condition. Keep exploring, keep learning.
Thanks for having me.
We'll catch you on the next deep dive.